Sorry, please, can you help me? I need to go to the VIP lounge for a presentation.
Okay, it's a
Thank
good
you.
day.
Yeah, thank you.
You're welcome.
Good morning, everyone. Welcome to this session on interventions to increase uptake of and retention in HIV services, a very important session for our last morning of the conference. My name is Sandy McCoy. I'm a professor of epidemiology at the University of California, Berkeley, and I am a last-minute substitute moderator here today, so please bear with me. And we are very delighted to have two fabulous presentations this morning, so thank you so much for coming. We will have, because our third presenter is not available, we will have extra time for a really rich discussion. So we will take questions immediately after the presentations. So be ready to engage, and we really want to hear your feedback. So let's go ahead and get started. So our first presentation is entitled, "I Came for Pads and Later Got Tested HIV Positive. Integrating Menstrual Health and HIV Services Improves HIV Testing Among Women." Our presenter this morning is Dr. Constance Mackworth-Young. She's an assistant professor at the London School of Hygiene and Tropical Medicine, based in Harare at the Health Research Unit, Zimbabwe. She's presenting this morning on behalf of Mandikudza Tembo, who's a research fellow at those same two institutions. She'll be presenting on how menstrual health can increase uptake of HIV testing among young women. Welcome.
Thank you. Thank you for the introduction, and thank you all for being here on this Saturday morning and last day of ICASA. So it's great to see you all. As you just said, I'm going to be presenting on behalf of my colleague, Dr. Mandikudza Tembo, whose work this really is. She is currently presenting her postdoctoral work in Singapore at the moment, so couldn't be here. But I'm going to be presenting about integrating menstrual health and HIV services and how this can improve HIV testing uptake amongst young women. Next slide, please. So because this is really an HIV conference, I wanted to give a little bit of background about menstrual health. So as I'm sure you know, over half the world's population will have a menstrual experience during their lifetime. Yet, most experience their first period with limited knowledge about menstruation. Others experience their periods with inadequate menstrual products, and still others experience menstrual complications without appropriate support or interventions. Women and girls often experience fear, embarrassment, and secrecy due to a lack of quality education and information. But menstrual health and sexual and reproductive health are very linked. They're both very linked to reproduction, but these health services are rarely provided together. And integrating menstrual health and sexual and reproductive health services may provide an acceptable and intuitive pathway to increase access to and uptake of sexual and reproductive health services, including testing and treatment for HIV. Next slide, please. Oh, sorry, go back one slide. Thank you. So I'm going to be presenting about the Chiedza trial. So this was a trial that was done in Zimbabwe, and the aim was to determine the impact of an integrated community-based package of HIV services combined with sexual and reproductive health services for 16 to 24-year-olds. And the impact was determined on the population level HIV viral load. So this was really an HIV intervention. It was delivered in 3 provinces across Zimbabwe: Harare, Mashonaland East, and Bulawayo, and it was delivered over 30 months. And there were 78,000 different visits to this intervention. So it was a very large-scale intervention. Next slide, please. And in this intervention, there was an integrated package of services that were provided. And this here, you can see the menu of services. So the menu of services for young men and the menu of services for young women. And I will just highlight some of the key services that were provided. So there was HIV testing and treatment. There was STI testing and treatment. Menstrual health products and information that I'll go into in more detail. There was contraception that was provided, pregnancy testing, counseling, condoms, and a text message information service that was that sent out text messages that gave information about sexual and reproductive health. So it was this really integrated package of different sexual and reproductive health services offered to young people. Next slide, please. So then just to go into a little bit more detail about the menstrual health service, because that's really the service that I'll be focusing on, particularly in this presentation. So young women were provided with or were offered menstrual health education, so information about menstrual health, analgesic, so pain relief for menstruations, and that was ibuprofen or paracetamol, and then a choice of menstrual health products, and this was reusable pads or the menstrual cup. And the women were offered a choice. They could choose one of those two. And if after 3 months of trying that product, they didn't like it, they could come back and swap with the other product. And then also in the menstrual health package, there was underwear, soap, and a period tracking diary. So the women could track when their periods were. Next slide, please. So this study examines the uptake of menstrual health services and HIV services amongst women in this intervention, aged 16 to 24 years. So in terms of the data that I'm drawing on, so all the young people who attended this intervention used their fingerprints as their identification, and this then collected data on the number of visits they did, so how many times they came to the CIEDSA intervention, their age and sex, and then which services they chose to uptake. So the providers would show them the menu of services, talk to them about the different services, and they could choose which ones to take up. And then we also collected some qualitative data. So we did focus group discussions and in-depth interviews with the clients, the young people who came to the intervention, and also the service providers who were providing the intervention. Next slide, please. So here is the service uptake amongst 36,991 young people who came to CIEDSA over the 30 months. Out of those people who came, 75% were female. So 3/4 of the people who came were female. And this graph shows the proportion of the eligible clients who took up each service. So I'll just very briefly touch on the men. And the three main services that they took up were HIV testing, condoms was the biggest one, and then also this text message information service. And then mostly I'll focus on the women, because I think here I'm looking at the menstrual hygiene service interlinked with the HIV services. And out of all the services offered, it was the menstrual health service that had the biggest uptake amongst women. So 95% of women who came to CIEDSA took up the menstrual health service at some point when they visited. Usually that was on their first visit, but several came several times. One person even came 24 times to the intervention. But at some point when they came, 95% took up the menstrual health service. And then over 80% took up HIV testing. So those were the two main services that were taken up by women. Next slide, please. And then just to zoom in a little bit about the menstrual health service. So we had these three main components of it: information, products, and analgesics. And most of the women, so 59% of the women, took up all three of these menstrual health services. And then 38% took up just information and products. And very few took up just one of those three components. So really the kind of combination of this service seems to be what most women took up. And then if we're thinking on a kind of programmatic level, this was an intervention that people could come back to, but most people actually just came once. So 60% of female clients just came once to this intervention. And at that one visit, so if you're thinking programmatically, if people are just coming once, what should we be offering them? So the menstrual health service was the one most highly taken up service. But what did they take that up with? So 49% took up menstrual health and HIV testing. 19% took up menstrual health, HIV testing, and contraception. And then 15% took up just the menstrual health service. So thinking about if you're doing one intervention or one seeing clients, this might be the combination of services that you might offer. And then looking at our next, we're a few slides back. Just go one more slide. that's the combination of the menstrual health services. And then the next slide. And that's the information about at one visit, what are the services that female clients took up. Next slide. So then looking at our qualitative data about thinking about why did this integration of menstrual health services and HIV services work? So firstly, a really key thing that I really want to highlight is the access to free services was so critical. Young women in Zimbabwe, it's prohibitively expensive to buy menstrual health products. And so providing these products and providing pain management for free was really important. So this quote saying, Chiedza helped a lot of young people by giving us free services. Condoms are expensive to buy these days. Pads are expensive too. So these free services were really helpful. And to me, just really showing the need for some of these quite basic health services. The second point that I want to highlight is that menstrual health services acted as a hook. So it increased, having menstrual health services increased female engagement with other services, with HIV testing, with other sexual and reproductive health services. And this quote saying, I came for pads and later got tested for HIV positive. So really showing that people came to the intervention for other services, and specifically menstrual health for females. They came because they wanted menstrual health products, information, and analgesics, and then they also took up HIV testing. And then the third point that we heard from the qualitative work was that having menstrual health services changed the outward face branding of the intervention. So it wasn't just an HIV intervention. It wasn't just an intervention if you were sexually active. It was an intervention if you were menstruating, if you were a young person, and this really reduced the stigma of the intervention. So this quote saying, young people do come to Chiedza as groups of friends. Two girls walked into the community center together and noticed their friend, and they all walked in and waved to each other in greeting. So this was, a friendly space. People weren't embarrassed to go there, and I think a large part is because it wasn't just for people who were having sex. So to conclude, I have three main messages. So the first one is that this menstrual health services were an incentive that brought young women to this intervention. And once they were there, they then learned about, heard about, and will be able to talk to providers about other services, so including HIV testing. I also really want to highlight that there's such a high unmet need for menstrual health information, products, and analgesics amongst young women. And it's a really critical gap that I think we need to be addressing. And then lastly, I think this really provides an example of an integrated sexual and reproductive health model, which includes choice. And that's choice within the menstrual health service about different products, about different services that they could take up, but it's also choice across a range of different sexual and reproductive health services that they were offered on this menu of services, and that they could choose which ones were appropriate for them. And this to me really is really critical to meeting young women's needs, and also could be implemented in different settings. So we're looking how this could be implemented in educational settings, primary care facilities, and also community-based settings. Next slide. So just to say thank you in particular to my colleague Mandy Tembo, who really is the menstrual health guru in our group, and also to the whole Chiedza research team, to our research participants, and to our funders. And thank you all for coming on this Saturday morning to listen.
Thank you so much, Dr. Mackworth-Young. That was a fabulous presentation. We have some time to take questions for Dr. Mackworth-Young now, so please raise your hand if you have some questions. Is there a microphone going around, or? Looks like there's a lot of questions, so we'll start right over here. Thank you.
Right. Thank you for a wonderful presentation. I have a question about the provision of free menstrual health products. One thing is that we know is that these things are not sustainable. Free things like this are not sustainable because most of this thing, people would depend on this free thing. How do you plan to sustain this? Because I've heard some people talk about reusable, helping the girls kind of try reusable menstrual product or like the pad. And you are providing a free one, and I'm just wondering if you can talk a little bit about your plan for sustainability. Thank you.
Let's maybe hear from 3 questions, and then we'll pass over to our speaker.
Good morning. Thank you so much for the presentation. I just want to find out, with the water challenges in Zimbabwe, do you have any information on how the girls are handling the issue of reusable pads? Thank you.
Thank you very much, and thank you for the presentation. I saw in the slide that you took biometric information from them. I just wanted to know how secure that data is. Thank you.
Let's go ahead and pause there and let the speaker respond, and then we can take another round.
Thank you, and thanks so much for the engagement. So the first question about sustainability, I think that's a really good question. We specifically use reusable products only. The reusable pads last for 2 years, the menstrual cup lasts for 10 years, and we also used period pants as well that can last, actually, I think for 5 years. So they're long term, and they're products that people use every month. And they're also not expensive. The reusable pads, a pack of 3 usable pads is $5. And so in terms of sustainability, I think they're almost one of the most long-term sustainable interventions that we can provide. I realize that they're not forever, but I think they are quite sustainable. Secondly, the water challenges, I think that's such a good point. And in a lot of the qualitative data, we talked about how the young women were using them and washing the pads. Most women were able to wash them, but actually something that we heard is that they were often felt shame about hanging them with the rest of their laundry. And so they'd find kind of other places to hang them, either inside the house, because they didn't want people seeing their pads on their washing line. So the water issues was an issue for some people, but also the kind of shame about pads being hung up on your laundry in a public area was also an issue. And then the security of the biometrics. This biometric system was phenomenal. So it was run by Simprints, which was this fingerprint system. And I want to use it in every research study I'm using because it was incredibly secure. We have no issues in terms of data security. And it means that you're not recording people's names. You're not recording any kind of personal private information about them, but you can link them through their fingerprints. And we were able, when we did the endline study, we were able to directly link people who were a part of the survey with their service uptake in the intervention. So I think it's, for other researchers who might be doing big trials like this, it's a really useful and very secure system for using. Thanks.
Thank you so much. I think we have time for one more round of questions for Dr. Mackworth-Young. You can put your hands up.
Yes. Yeah, from my side, I'm Tefadza from VESA-HI. So just wanted to find out, how do you implement your follow-up services? I think if you look at the community-based model, when you initiate them, for example, on SRH services or maybe contraception or PrEP, at some point they need to come back for their follow-up services. So in a community-based program, how do you now manage to make sure that they can be able to be seen again for the follow-up so that we can sustain any prevention methods that we are providing? Thank you.
So if I heard you, I'm Linda Sandam with the Health Economics and Epidemiology Research Office in South Africa. So if I heard you correctly, the services were such that people would come a number of times to access them, but a significant proportion just came once. What do you think was the reason for that? Mm-hmm. Thanks.
Okay, one final question.
Yes. I'm Swilan Sivita from the Ministry of Health, Zambia, here. My question is really similar to the question asked by the gentleman. Wonderful results from the CHIESA. The question is a model of probably scale up these services. Sounds like this was really a facility-based model. You do HIV testing, STI testing, and that sort of thing. If we are going to adopt such integrative model. Just your thoughts on what's the best way of scaling the bar? Is it community, facility, or a bit of, blended model? Thanks.
Thank you, everyone. Let's go ahead and ask Dr. Mackworth-Young to respond.
Thank you. What a treat to have such a range of interesting questions. So I'm starting with Tafadzwa in terms of the follow-up services. And I think that's such a key point, and it kind of links to the previous question about sustainability. So that was specifically important for the young people living with HIV who came to Chiedza. So there were some people who already knew that they were living with HIV before they came to Chiedza, and they on the whole, stayed with their healthcare provider that they were already getting their treatment from. They were offered that they could change to Chiedza and get their treatment through Chiedza, and some did because they felt it was an easier way to get their treatment, but a lot stayed with their existing provider. For those who newly tested positive through Chiedza, they again had a choice to either link to care through the health facilities or through Chiedza. And then when Chiedza ended, all those who were getting their treatment and support through the intervention were linked to care through quite a supported long process. Having said that, it was an intervention that ended, so it ended after 30 months. And I think a lot of the people, particularly the people who were living with HIV, felt quite disappointed and sad that they were that their care was being moved. Thank you, Linda, for your question, and nice to see you. So why do people just come once? I think that's a really good question. And I think a lot of the services one might just want once. So you might just want to be tested for HIV once. The menstrual hygiene products, you got them and they would last for the next 2 years or the next 10 years. And although people could come back and swap their products, very few did. Most people were quite happy with the product that they chose. Most people chose reusable pads. So from the menstrual health service, there wasn't necessarily much of an incentive to come back. You got your products, you used them at home. And for other services, some people did come back particularly for contraception. So people came back kind of repeatedly for contraception. But otherwise, a lot of the services were something that people might just want once. And then the last question from the Ministry of Health in Zambia, how should we adopt this model? And I think that's a question that we're grappling with now, and we're in a lot of conversations with the Ministry of Health in Zimbabwe. How can we have a kind of maybe less Mercedes-Benz intervention that could be more sustainable and integrated? And we're talking specifically about how, I think one of the key benefits of this was to have this range of sexual and reproductive health services all in one place, and how can we fit that into the existing system? And those are some of the conversations that we're having at the moment. So yeah, thank you for that question.
Thank you so much, Dr. Mackworth-Young. It's fabulous. I think we'll move on to our next presentation, but we will have time for questions after the second presentation, so please hold them as well. If we could please load the slide of Dr. Katabaro. So I'm delighted to introduce my colleague, Dr. Emmanuel Katabaro. He is trained as a medical doctor and is a research director at Health for a Prosperous Nation in Tanzania, which is a research organization. His presentation today is the impact of financial incentives on viral suppression among adults starting ART in Tanzania, a cluster randomized trial. Welcome, Dr. Katabaro.
Thank you. Good morning, audience. Today I'll be sharing with you on the impact of financial incentives on viral suppression, among others, starting HIV treatment in Tanzania. This was a randomized, cluster randomized control trial. And this has been a saying in our communities, in our organizations, that we can't use financial incentives to deliver HIV care because after we withdraw, because the financial incentives cannot be forever. And if we withdraw incentives, we may face worse results because people will withdraw from care, and we will not be able to sustain the bad impacts of financial incentives. So we did this randomized control trial to find out what is really happening with the science and be able to share with whoever was had that notion and see what's happening in reality. Next slide, please. So financial incentives may strengthen the HIV continuum of care. And as we know, Approximately 1 in 4 people living with HIV in Eastern and Southern Africa is not virus suppressed. And we hypothesize that financial incentives may help to nudge people and the improve retention in care and viral suppression. We conducted 2 preparatory studies to develop and pilot the intervention. In an initial study, which was a pilot, we found that small financial incentives improved appointment attendance, increased ART possession, and reduced LOTF flows to follow-up against the usual care, and they were as effective as better than food support. And in a subsequent optimization study, we found that small financial incentives improved retention in care with viral suppression by 13 percentage points against the usual care, which is the usual HIV services in the country. So although these findings were beneficial and promising, there was no any study that was done at a large scale to evaluate their possible benefits on HIV outcome in sub-Saharan Africa, including their benefits or harms after discontinuation, which was the main discussion. So next, we conducted a hybrid effectiveness implementation trial to evaluate the effectiveness of small short-term financial incentives in the region of Tanzania. The study was a cluster randomized trial of others starting HIV treatment, a period often characterized by high mortality and attrition from care. So these 32 HIV clinics in 4 regions were randomized 1-on-1 into intervention and the control. And the primary outcome was retention on ART with the viral suppression at 12 months. So that was the main outcome that we wanted to measure in relation to these financial incentives. And overall, 1059 people were included in the intervention group, and 931 patients were in the comparison group. And the intervention was available at 12 months for 95% of patients, and the 5% accounted for LOTFs that could not be traced, and the death that happened for participants who were into the study. Now, in the incentive intervention that we had at the main, all 1990 participants in the study in both arms were subject to the standard services of HIV services in the country. And now the intervention sites, which were 16, their participants were subjected to consecutive 6 months of up to 6 financial incentives of approximately $10 that were given conditional on a visit attendance. So if I'm into the intervention group, I'll be subjected to up to 6 consecutive financial incentives conditional on attending my visit. So the intervention was theoretically based and designed, and it was in collaboration with the local experts, stakeholders, and in collaboration with our advice from the Ministry of Health of Tanzania. Next slide, please. So the purpose of this implementation and the trial was designed to rigorously assess the intervention effectiveness and address outstanding gaps in the HIV literature, as I said, such as whether results from pilot trials are replicated at a larger scale and whether incentives have benefits or harms after they are removed. So the incentives intervention was implemented for the first 6 months and added to standard HIV care services, which were offered in each study arm. So the intervention sites were supplemented with the normal usual care services, and now the control sites were on the usual standard of care services in the country. So we collected data at baseline 6 months and 12 months, and we measured, and the measurements included participant surveys, abstraction of medical records and laboratory data, and the qualitative implementation interviews that were completed to account for the implementation part of the trial. So data collection, we had an IWEF that was designed for the study, and we used that, and that was used for all the study activities, including viral loads, which were imported via the API from the database into the MS system, and all study enrollments and surveys were completed based in the MS with biometric fingerprint identification. So clinical information like visit days and the pharmacy dispensing information, as well as incentive disbursement information, were also collected directly into the MS system that we had by the clinical staff. Next slide, please. So we use standard statistical methods, including a permutation test and the intent to treat analysis to estimate the effect of the intervention. We conducted subgroup analysis by region and the facility sex and the age. We also conducted a variety of secondary and sensitivity analysis to confirm the robustness of the findings, including adjusted models and the use of multiple imputations for the missing data. Next slide, please. So those were our baseline characteristics. And at baseline, both clinic and individual characteristics were balanced between the comparison and the intervention groups. And this is the result of randomization that happened between the two groups. So overall, study participants were on average 36 years of age, and females were 59.5, and 46 had completed primary school. And the average time on ART for those participants who were in the study was 3.5 days. So all these participants were 3.5 days since initiating ART, meaning they were new ART initiates. So our main results, retention on ART with viral suppression was high in both study groups. So, and as we can see, we had 90.4 in the intervention group and 85.5% in the control group. Both were virally suppressed and retained on ART at 6 months. And now at 12 months, we had 84.9 and 80.6 percentage as retention, as participants that were virally suppressed and retained on ART at 12 months. So at 12 months, incentives, at 6 months, incentives modestly had modest, significant incentives modestly, but significantly increased retention in ART with viral suppression at 6 months with 5.1 percentage point difference. So in that 12 months, statistically no difference from 6 months, but not significant. We found no evidence that incentives harm retention or on ART or viral suppression at 12 months, 6 months after their discontinuation. So this was the main outcome that we found out, and that was the main talk in the healthcare system. And we have been able to find this evidence that there is no harm, and if there is a need to use these incentives, these are the findings, and we can apply them in delivering HIV care. And now effects were stronger using the below 50 copies per mil cut point for viral suppression, whereby we got 8.8 and the 5 percentage point difference, both at 6 and 12 months. So the study was pre-specified to use the below 1,000 copies per mil as a means of viral suppression. So this was the main analysis. But when we did below 50 copies per mil cut point, that's where the effect was huge, both at 6 months and the 12 months. So this means if we need to have stronger effects and have the below 50 copies per mil, which is undetectable viral load for patients, we may need to consider financial incentives. So, and we also had a regional heterogeneity. So we can see in one of the regions, which is Kagera, we did not have any strong effects, both at 6 months and 12 months. And we think this was possibly related to, due to high relatives in one of the two sites in that region that had migrating workers coming for work in industrial areas. So we think this might have been the cause. So on the cause of having the lower effect in this region. So, but the effect was profound and large after excluding this region, and we can see at 6 months and 12 months. Next slide, please. No, one slide back. Yes, so at 6 months and 12 months, we had 8 and 70.4 percentage point difference. So the possible pathways of impact. So we came to find there was, we confirmed that clinic level fidelity of the intervention was extremely high across all 16 intervention sites. We found that participants at intervention facilities had a significantly higher proportion of scheduled visits attended on time within 4 days compared to those of comparison sites, both at 6 and 12 months. Specifically, intervention participants were 10 percentage points more likely to attend the visits on time for ART reviews at 6 months compared to control sites. This could explain our findings for increased viral load on the previous overall results. So the strength of our study, this was a rigorous effectiveness implementation study that addressed outstanding questions about the benefits of financial incentives on HIV viral suppression. The study also developed and evaluated a scalable implementation model, and this was presented at the poster over this ICASA over last Wednesday. So as well, this study is the largest to date of the effectiveness of financial incentives on HIV viral suppression in Africa, and measured outcomes after incentives had been discontinued. So many studies have not been able to measure the outcomes, and some studies or practices did not measure any outcomes with the use of financial incentives. So we used best practices for data collection and multi-step approach to participant tracing to minimize or eliminate bias introduced from site transfers. So the site transfers, these are the participants who you find missing, and later, after extensive tracing, you find that they are in care and they are taking their medications. So we made sure we are able to find these silent transfers and be able to confirm if they're in care or not in care. Our findings are robust to various model specification and sensitivity analysis. So we have limitations. This study was initiated before COVID, and in between along the study, that's when we were hit with COVID. So we had some background temporal changes. For example, during the period of the study, there was a DTG regimen rollout. As we know, this is so effective, so it may have limited comparability to prior studies that used the other ART regimen. So contemporaneous changes in the viral load threshold for defining success on ART also occurred during the trial, and this means clinical and policy relevant outcomes were not pre-specified. So as you see, we had to do the analysis on the viral suppression based on the 50 copies per minute cutoff, which was now the point of interest with suppression and So the key takeaways. Viral suppression among those retained on ART in the comparison group was high, and this is the testament to Tanzania's concerted efforts to achieve the 95 goals. And financial incentives yielded modest but significantly improved outcomes on retention on ART with viral suppression at 6 months. This effect was statistically similar at 12 months, 6 months after discontinuation of incentives. Incentives did not harm retention in care or viral suppression even after 6 months after they ended. Reanalysis using the threshold of below 50 copies per mil revealed stronger effects of the intervention, possibly related to small shifts in compliance with visit schedules, because you need to be compliant with adherence to be able to have the undetectable level of below 50 copies per mil, rather than the 1,000 suppression threshold that could be attained even with less adherent practices. So incentives may be well suited to the subgroup of people living with HIV who need more support to be successful on ART. So as we say, since we may need to use incentives to provide HIV care, so we may apply these to special groups. For example, the loss to follow-up. Can we use these incentives to keep them back to care, as we have seen the outcomes from the study? Also, can we use these outcomes to children who have outstanding problems with suppression? So these are the areas where, and the other possible areas where the incentives can be utilized. And the acknowledgements, I would like to acknowledge Earth for the Prosperous Nation. This is the base organization where this study was listed. And the Ministry of Health of Tanzania, and our collaborators, University of California, Berkeley, and the Management and Development for Health was the implementing partner. And Racero, this is the tech company that developed our MS. And finally, the funders, the US National Institute of Mental Health, NIH. Thank you.
Thank you, Dr. Katabaro, for that excellent presentation. I'd like to invite questions for Dr. Katabaro. Do we have the microphone going out around? Let's take 3 questions now. Thank you.
Thank you very much, and that's a very comprehensive research. My question was, were confounding factors taken into consideration when we, the final conclusion of when incentives are stopped, it doesn't really have much on retention, because there are some places where distance may be a problem, demographics, their career, I mean, income level and everything may. So were they considered when this research was being done? Thank you.
Thank you very much. It was very striking that you had really very good retention in the incentives and in the non-incentive arms. And although you did show a modest impact, I'm just wondering about the cost effectiveness of this. I'm from WHO, and we're always slightly wary about incentives for any health intervention, because why HIV, why not diabetes, why not hypertension? It could become extremely costly and unsustainable and potentially increase inequity. So I'm wondering what your kind of lessons for the future for Tanzania would be from the study.
Thank you so much. My name is Kozi Ziambo from the Ministry of Health, Zambia. And it's very interesting to actually learn from this work that you have done. I just wanted to check with you how you know that incentives always invites people, even those that may not necessarily be eligible. But in this case, how did you manage to filter off those that may already be on treatment from other places coming through to join, to initiate from your side? Some of the problems that we're experiencing in our country, and we're trying to mitigate that. But now introduction of an incentive also worsens that kind of problem, where you have got people who already don't coming so that they may benefit from some incentives. Thank you.
Let's let Dr. Katabaro answer those questions.
Thank you for the nice questions. And the first was on the confounds. So as we know, this population of the people starting ART, they kind of have the same economic, similarities. And in the communities, we also have other programs that were ongoing. And we made sure that we asked also of the same activities that might have been going into the facility, into the communities. And yeah, so we made sure we keep into consideration of all the confounders that may lead to, that might have led to influencing our results as well. So another question was on retention that we say was high. So and the question was on cost effectiveness and sustainability. Yeah. So on the issue of sustainability and cost effectiveness, so this was a first step, I could say, as a means of finding evidence and showing that incentives have no harm, and this is the most probable outcome. So what should we do? Can we apply, like I said on the closing remarks, that can we now apply them to some specific groups that may have problems with virus suppression and the care, maybe even care-seeking behavior in other groups. So we think it's now up to police if they can incorporate all these and they be able to optimize the